if we start from a targeted therapy, can you salvage patients treated with venetoclax, right? And I think that sometimes comes up with primarily in the context of someone who had like received FLT3 inhibitors in combination with chemotherapy, or like this is some retrospective data, maybe a little bit dated. So I feel like probably someone who had an IDH inhibitor previously, and then venetoclax-based therapies were approved. So some patients were in that realm. So that was more of a heterogeneous patient population. But I think what's interesting here is that venetoclax-based therapy still had a pretty reasonable response rate of, I think, 55%, and with a median overall survival of 9 months, which is not bad in a relapsed refractory AML setting. And I think similar to what we just talked about with gilteritinib being a potent salvage therapy option in patients that had previously been treated with azacitidine with venetoclax-based combinations, we could also see that like 6 out of the 7 patients with an IDH1 mutation who had previously been treated with ivosidenib responded to venetoclax-based therapy. And I think that really is also supported by what we know from azacitidine and venetoclax in the frontline setting, that IDH mutations are very sensitive to venetoclax-based therapies. So I think it's interesting to see that we can replicate this in patients who had already been on the IDH inhibitor. So I think that is one of the interesting takeaways from this too. However, both studies are retrospective, and they certainly have limitations in terms of selection bias, in terms of treatment differences. So I think it's really important to not overemphasize those results, because this can really only be answered by a randomized clinical trial, which I'm not sure if it's ever going to be conducted, and that's why I think retrospective analyses are important in that context.